David and Axel, thank you for the invitation to be here and to talk about emerging concepts of immunotherapy in GI cancers. Those are my disclosures. So this is the slide that I always like to start off with on any talk on immunotherapy, to talk a little bit about the background of immunotherapy. And this surgeon here, William Coley, was really the founder of immunotherapy back in 1891. He was a young surgeon at what would become Memorial Hospital and was motivated to try and find new therapies for cancer after a patient of his, Bessie Dashiell, had died from a sarcoma. He subsequently noted in a patient with head and neck cancer who developed erysipelas over the tumor that the patient had a spontaneous regression. He then made that association very astutely between inflammation, innate immunity, and tumor regression, and tried to repeat that by extracting bacterial products and injecting them into patients. This was the first patient that he apparently treated that way, who had a head and neck cancer, who had a regression, and this was published back in the late 1800s. This began a 123-year story from what would become Memorial Hospital, which was about 3.6 miles straight up 8th Avenue. You'll get to where immunotherapy began. Over the next 123 years, immunotherapy went through various iterations, mostly vaccines, melanoma. For the most part, from a clinical standpoint, stayed under the radar because it wasn't effective in patients. And more recently, over the last 10 years, we have learned how this balance between an effective immune response and an ineffective immune response is controlled, and hence led to the era of co-stimulatory molecules. There is a plethora of various molecules that interact between a T cell and an antigen-presenting cell, and ultimately between a T cell and the tumor that controls the balance. You can think of the immune system as a lot of T cells that really just putter around the body. When they see something that looks slightly different, they get somewhat interested. They then rely on a signal to tell them to become more interested, which immediately leads to a signal that tells them to stop. If we either make that initial activation signal stronger with an agonist, we can augment the immune system, or if we take away that negative signal with an antagonist, we can prevent inhibition and we can have effective immunity. And we are now in an era where we don't talk about tumor immunity, we talk about melanoma immunotherapy, lung cancer immunotherapy, and we are now going to start talking about immunotherapy in GI cancers. And the fundamental reason we're going to do this is because GI cancers are immunogenic. However, they present diverse challenges as well as opportunities for the development of immune therapy. And in a general concept, the major challenge could be because they develop in an immune suppressive microenvironment that is permissive for commensal microbiota, a challenge not faced by other types of tumors. One of the other challenges is that usually they do not develop in association with carcinogens and a high mutation burden, like lung cancer and smoking, or melanoma and ultraviolet exposure. However, there are exceptions. This is a almost mandatory graph or figure at this point for any immune therapy talk. And this was taken out of a paper by Alexandrov that was published in Nature. And the intention here was to show somatic mutation prevalence. And here, each tumor is represented by a set of dots, and each dot here is the mutation prevalence in a log scale. This indicated how different mutation burden is amongst tumors. From an immunology perspective, what jumped out here is that the tumors on the right side with the highest mutation burden is melanoma, followed by lung cancer, which made everybody think at that point that the major determinant for an effective immune response is mutation burden. And that may very well turn out to be correct, but it's really being studied further, but it's very compelling. But from a GI perspective, what you really want to notice here is that colon cancer is right there. Right? It's in this area here. There it is. And on the right side of colon cancer are the highly immunogenic tumors. On the left side are other highly immunogenic tumors that respond to immune therapies, and colon cancer is right in the middle. So colon cancer has the potential for an immune response if it really is dependent on mutation burden, yet there's something else that's blocking it. And that's the challenge that we have moving ahead. One of the other observations that's important to note is that these mutations lead to epitopes. This is an example of this. This is a proof of principle study that I did and published back in 2008, where we took the somatic mutations published by Bert Vogelstein's group, 1,152 mutations in colon and breast cancer. Using epitope prediction algorithms, we show that each set of mutations results in 7 to 10 novel epitopes per tumor. And each of these epitopes can be considered as foreign as if it were a viral antigen to the immune system with the potential of an immune response, and these are very different. The next challenge is making this stronger. This is the graph of immune modulation, and this tells us at which points we can augment the immune response so that these epitopes that are released when the cancer cell dies, either spontaneously or if we treat it, until there's an effective immune response. The points at which we intervene is either through cancer antigen presentation, such as with GM-CSF, or we prime and activate the T cells stronger. That's where anti-CTLA-4 comes in. Or we get T cells to get to the tumor, or we get them to move in, perhaps with anti-VEGF therapies, or we enhance recognition of the cancer by the T cells and ultimately killing. Of these, multiple are in clinical development, and I've only highlighted the ones that we're actively studying now at Memorial Hospital. So perhaps this is a time to take a step back, and how can we get immunotherapy in GI cancers to be as effective as in melanoma? This is a graph from combination nivolumab, ipilimumab in Jed Walchuk's presentation from ASCO and published in New England Journal. Or how can we be as effective as in this patient with a head and neck cancer? This is from a patient treated with MEDI4736 that was so far presented at ASCO. After 2 doses, that head and neck cancer went away. So we are envious in a GI world to see these kinds of responses. So what have we seen so far? The first set of tumors that I'm going to talk about is colon cancer, to remind ourselves of the effects of immunotherapy in colon cancer. So 4 studies. The first one is a study that was done by my colleagues at Salz and Kiang Chung. This is the Pfizer anti-CTLA-4 tremelimumab. This was a phase 2 trial, 47 patients. The drug was given at a higher dose, less frequently to what it's given now. Of the 47 patients, 46 came off study after only receiving 1 dose of therapy. Perhaps we missed an opportunity to see responses or delayed responses, which we know is very important in immunotherapy these days. Of the 1 patient that stayed on study, there was a remarkable response that lasted for 15 months. And here you can see regression in a pelvic lesion, as well as a adrenal met. A more recently published study using the anti-PD-L1 from Roche Genentech. This was a phase 1 study presented by Joseph Tamanera at ASCO. Multiple tumor types. There was a patient with colon cancer that had a partial response to anti-PD-L1. Here you see in a pleural-based met, there you see in a liver met. The next example was nivolumab. When nivolumab was initially developed by BMS, there were two phase 1 trials. The first trial was a single-dose trial. The second trial was a multi-dose trial. 20 patients with colon cancer were treated. 19 patients progressed, i.e. nivolumab by itself is not an effective therapy by any means in colorectal cancer. But 1 patient had a marked response that went on to be a complete response. Further looking at this patient, it was interesting that if you look at the H&E section, there was high PD-L1 expression that we think of as a marker of response to anti-PD-1 therapies. You see the PD-1 on the infiltrating T cells, which are present at the periphery of the tumor. This patient was also microsatellite high. Perhaps one of our first insights into the fact that patients with Lynch syndrome or microsatellite instability are going to be potentially very good targets of immunotherapy. So just to talk about that for a minute. So Lynch syndrome or acquired DNA mismatch repair deficiency to the immune system is the same thing. This deficient DNA repair system leads to microcellular instability, but from an immune perspective, this leads to DNA frame shifts, an expression of frame shift peptides. Frame shift peptides, we know, can be recognized by the immune system. So several groups, predominantly in Europe, have looked at this and have identified using ELISpot assays that the CD8 T cells in the periphery of patients with Lynch syndrome are increased and specifically recognize frame shift peptides, so do antibodies in the periphery. This is also seen in patients with Lynch syndrome who never went on to develop cancer, so perhaps there's an effective immune response that prevents cancer, maybe, but at least we know that in patients with Lynch syndrome, they have an activated T cell response that we need to make stronger. And there are 3 clinical trials now going on specifically looking at that. We have one at Memorial using anti-PD-L1. There's a BMS trial using nivolumab as well as ipilimumab that Scott is involved in. And then there's a Merck trial that is looking at these patients as well. The next group of tumors to look at is gastric cancer. I'll go through some of the anecdotal successes because there's a lot more recent impressive successes. Some of the interesting ones were a response in one patient with anti-PD-L1, in Joseph Cabanero's presentation from the phase 1 trial, and then in a prior trial of anti-CTLA-4. This was a phase 2 trial, 18 patients in the second line, at the higher dose every 3 months. I say higher dose because now it's 10 mg per kg more often. 4 patients had stable disease. 3 of 13 patients had a biochemical response, 1 partial response, albeit a pretty impressive response in that pelvic met. But we know that immunotherapy works in gastric cancer. And more recently, this is a clinical trial of anti-PD-L1 with the MedImmune MEDI4736. This is a incredibly large phase 1 trial, about 800 patients so far, 15 different tumor types. One of the cohorts is gastric cancer. Here you see a spider plot where you see each individual tumor getting bigger or getting smaller. And here you see the waterfall plot showing the regressions. 1 complete response, many patients benefiting. The patients that have met the minus 30% RECIST point was only 2 at this juncture. Most patients are still staying on study. So anti-PD-L1 therapy in a non-PD-L1 selected cohort is very interesting and is being studied more. But then we have the pembrolizumab data, and this is from the Keynote 012 study, which is the phase 1 trial, specifically looking at the gastric cohort. And they are focusing on PD-L1 positive patients. Of the initial 162 patients, 65 or 40% were PD-L1 positive. There's many different ways to determine PD-L1 status. Here they looked at stroma and defined a cutoff of 1%. Within this cohort of patients, initially they reported a 30.8% response rate. They looked to see whether it was uniform between Asian and non-Asian subjects, and it was. And more recently at GI ASCO, they presented an update of this data, and per investigator review, the response rate is 33%, and per central review, the response rate was 22%. The median time to response was 8 weeks. The median response duration was 24 weeks from 8 and 33 weeks continuing. And they also showed that the level of PD-L1 expression was associated with the overall response rate. If the cutoff was higher, the response rate went higher. And the 6-month PFS rate was 24%. 6-month survival rate, 69%. Pretty impressive for a chemorefractory gastric cancer population. The next group of patients are the hepatocellular cancer. So this includes hepatitis B virus infection, hepatitis C virus infection, or no virus. One of the earlier trials was of tremelimumab anti-CTLA-4, a phase 2 trial, HCV positive patients, the high dose of tremi every 3 months, response rate of almost 18% with a time to treatment progression of 6.5 months. They also showed a decrease in HCV viral load, which was associated with an enhanced anti-HCV immune response. So perhaps a viral, targeting the virus component may impact, but the efficacy of an immune response against a viral component of a tumor is really unfolding, and so far the data is not compelling in other types of tumors, particularly head and neck cancer. This was the cohort from the MEDI4736 trial that we're partaking in, and here you can see in the swimmers plot, some patients are responding. The responses in HCC are delayed when they do occur, but there are a proportion of patients showing an impressive response, none of which has met the criteria for RECIST response. The one that did go beyond 30% had a new lesion, therefore, by definition, progressive disease if you use conventional RECIST. The fourth type of tumor that I'm going to talk about is pancreatic cancer, which, just to point out here, pancreas cancer is a low mutagenic tumor. We're already at the left side of this graph. There are at least 10 times fewer mutations in pancreas cancer compared to melanoma or the more immunogenic mutagenic tumors. But a trial of ipilimumab, anti-CTLA-4, phase 2 study, 27 patients. None met the criteria for having a response, but clear benefit here in 3 patients with shrinking tumors. And in our MEDI4736 trial, you could see a fair amount of patients having tumor shrinkage. Again, a delayed tumor shrinkage when you compared with melanoma, but pretty impressive when you look at the waterfall plot. The actual RECIST response rate is 2 out of 29. And this is an example of a CAT scan from one of our patients that we treated at Memorial, 59-year-old man. He had progressed on prior gemcitabine as well as FOLFIRINOX. His tumor was PD-L1 negative, and he had tumor regression. Here you can see this lung met, much smaller after 6 weeks. He was staying on study for approximately a year and a half. So I've covered the experience of what has worked in GI cancers in immunotherapy. The question now is, what are the trials that are going to be done in the very near future? A year ago when I gave this talk, there were very, very few trials. I expect in a year's time, there's going to be results from some of these future trials that are being done. This is just an example of what's being done in gastric cancer now. So the PD-1 pembrolizumab by itself in multiple tumors, a specific trial in gastric and gastroesophageal cancers, in combination with chemotherapy, and in combination with CTLA-4, whether it be the MedImmune drugs or the BMS drugs. In pancreas cancer, there's monotherapies in resectable or borderline resectable patients. There's a combination with radiation as a mechanism to release tumor antigen. There's in combination with chemotherapy, and there's in combination with CTLA-4 blockade. In colon cancer, there's a PD-1 in combination with chemotherapy. There's a PD-1, the pembrolizumab Merck drug, in combination with azacitidine, which is a demethylator to result in antigen expression. There's the trials that I mentioned in microcellular unstable patients, so very promising trials, from a mechanistic point of view, in combination with angiogenesis, in combination with CTLA-4 blockade. In liver cancer, there's trials as well. I just mentioned two here. There are more of anti-PD-1 by itself and in combination with chemoembolization. This is the trial that we're doing of the anti-PD-L1 in immunological subsets of patients. And here we're looking at patients with DNA mismatch repair deficiency, but also patients that have microcellular stable tumors, but for some reason have an increased tumor-infiltrating lymphocytes. So they look like they're DNA mismatch repair deficient, but they're not really. So that's the eligibility, either increased TILs or mismatch repair deficient. They should have received prior therapy. It's a Simon two-stage design, single-arm phase 2 study, and we'll give them treatment every 2 weeks for a year. After a year, if they're benefiting, take a break, which is standard for most immunotherapy trials, with the option to be retreated if they have disease progression. The other trial that I want to mention that we're doing, I'm going to start with some of the background. This is a combination of cetuximab and urelumab in KRAS mutant, wild type, and EGFR progressed patients. Urelumab is a T-cell agonist, and so cetuximab will bind to the tumors. It doesn't do much as far as EGFR pathways go, but it does attract natural killer cells. They become aware of the cetuximab, they bind to it, they don't do anything, but they upregulate a molecule on their surface called CD137, which is an agonist. If you then come in a day later with anti-CD137, you augment the NK cells, and they should be targeted. So this was the murine study done by Holbrook and colleagues, showing that if you give either cetuximab or urelumab by itself, there isn't much of a benefit. If you give the cetuximab and urelumab at the same day, there's some benefit. And if you give them 1 day apart, allowing the NK cells to upregulate the CD137, there's even greater benefit. So in our clinical trial design, patients get cetuximab weekly and urelumab the day after every third dose. The key eligibility for this is patients with advanced colorectal cancer. As I mentioned, they have to have failed standard therapies. KRAS status doesn't matter for this trial. There's also a cohort of patients with head and neck cancer. It's a regular safety and efficacy clinical trial, cetuximab every week. This is another interesting trial, the last trial I'm going to talk about, just a different way of looking at the immune system. There is more than just the checkpoint blockers, although at some point they will be combined. This is a Roche Genentech trial, and this is an immunocytokine combining an engineered IL-2, which is a variant of IL-2. IL-2 activates CD8 cells, NK cells, as well as regulatory T cells. If you change the IL-2 to lose the high affinity binding, it doesn't engage Tregs, which will suppress the immune response. It only activates the effector arm of the immune response. By being a bispecific antibody, it binds to CA within the tumor and brings in the IL-2. That should allow us to take colon cancer. It has a lot of mutations, but T cells can't get into it. If you have a lot of IL-2 in the tumor, that should bring the CD8 cells into it, and hopefully will augment the immune response. The next generation of this will be combining it with anti-PD-L1. standard criteria for refractory disease. So in sum, GI cancers are recognized by the immune system, including colorectal cancer, gastric cancer, pancreas cancer, and hepatocellular cancer. GI cancers may be targeted by an augmented immune response with clinical benefit, albeit in a subset of patients. So we need to study monotherapies and combination therapies, including immune checkpoints, chemotherapy, and local therapies. And we must identify patients who respond to immune therapies so we can identify predictive markers and focus our future clinical trials. Thank you.